All right, welcome to part two. We're going to pick up back where we left off on infections. So, pediatrics, as we already know, have an immature immune system. So, they're going to be minor, but they can lead to pretty significant systemic release of those neurotoxins. Big things that are going to be our most prevalent on life-threatening illnesses of infections are going to be our meningitis, pneumonia, and sepsis. Signs and symptoms of a possible infection are going to be fever, chills, tachycardia, dehydration, poor perfusion, respiratory distress, nausea, vomiting, purpura, bulging fontanelle, stiff neck, which is going to be seen in our meningitis, seizures, school claim skin. You're basically going to know when you see a sick baby. Some of your assessments here. Treatment and management is going to be, BSI, scene safety. Kind of just do your best with keeping a sterile environment, the spread of infection, and treat the underlying cause depending on what it is. Respiratory emergencies, just have a relaxed approach. If you look like you're shitting your pants on scene, the patient's probably gonna see the same and match your energy. Respiratory stress is just going to be kind of what it sounds like. You're just going to have an increased respiratory rate. You're not going to be able to blow off that CO2 efficiently, kind of leave you alkalotic. But this is the most mildest form of a respiratory compromise. You'll kind of just see tachycardia, retractions. Nasal flaring is a really big sign in this. Head bobbing, grunting, cyanosis. If this is not corrected in a timely manner, this will quickly turn into respiratory failure, where you'll kind of see a decompensation in your patient's outcome. This is more seen in the fact that your metabolic demands, that O2 for glycolysis and the Krebs cycle, cannot be met, and CO2 is not being removed from the body, even furthering your acidosis as you swap over into anaerobic metabolism. So here we have our ventilation. O2 is not good at all. Here we go, your acidosis. You're going to see, now you're going to be presenting with lethargy, bradyapnea, agonal respiration, central cyanosis, and hypoxia. If this is not corrected, you are very quickly going to be understanding PALS. So this is going to be cessation of breathing, and you are now going to have to start working this child, securing airway, and pray to God you still have a pulse by the time you're done. Signs and symptoms: unresponsive, apneic, asystole, sometimes here, or profound cyanosis, blue baby. Management on this is going to be assess the airway. You need to be extremely vigilant on maintaining their oxygen. Be very aggressive with your treatments. They will perk up pretty quickly. They'll respond very well to most treatments you do, but just if you are going to be lacking in your initiative, they will quickly decompensate. And it'll be a little bit more of a challenging haul for you. We have our upper airway obstruction. We already talked about this, partial or complete. Go ahead and put them in a position of comfort, or try to get them to cough out. If not, then we'll be doing our Heimlich maneuver or CPR if they go unresponsive. We have our croup. Croup is a pretty cool one here. So this is going to be labeled as laryngeotracheal bronchitis. It's a viral infection of the upper airway. So this is able, like epiglottitis, to create a complete airway obstruction. You need to be very careful with handling these patients. Any startling, any trauma, anything like that, your respiratory tract can inflame so much to where you are unable to get a actual visual on the vocal cords, and you're going to probably have to opt into cracking the child. So this is going to be in the supraglottic region, inflammation. So this is going to be leading to edema beneath the glottis and larynx, which will narrow your airway. So it's going to be the slower onset. Unlike epiglottitis that we'll talk about in a second, you'll have an inspiratory stridor, seal-like bark, no drooling, and a low-grade fever. Best way that I remember a croup is by some C's. So you have your, what do we got here? I forgot my mnemonic. But we have our treatments at least. I'll come back to this in a second. I think I wrote it down somewhere. But croup, it's going to be cool air, so we can reduce that supraglottic edema. Racemic, using the C again, racemic epi is going to be your drug of choice. So cool air mist, racemic epi, albuterol if you need to, or corticosteroids. Don't visualize the airway, please do not. If you have a celiac bark, just understand what's going on here. Sometimes when you do walk your patient out to the stretcher, that cool air, the environmental, it may actually reduce that supraglottic edema by the time you get to the truck. And low-grade fever. Yeah, slow onset, maybe a calm, slow onset. Epiglottitis now. So epi, as we know, so if we use the first prefix here, epiglottitis is very high, fast heart rate when we give it in a pharmacological standpoint. So you're going to see high fever, and epi is a fast-acting drug. You're going to see a fast, rapid onset. So very acute. This is going to be the inflammation of the epiglottis itself. So if you do inspect the patient's airway, you might actually see in the pediatric population the anterior border, posterior border of the epiglottitis. Typically, we'll be seen in our 3 to 7 year olds. You'll have painful swelling, sore throat, like epi is, very high, fast-acting drug. You'll have a high fever, nasal flaring. And with our management here, we're going to be humidified O2, prevent the drying of that epiglottis. We have our bacterial tracheitis, viral croup. It's basically just another form of our epiglottitis. Just give humidified O2, prevent the drying of the epiglottitis. More foreign body airway. We've already talked about this, so I feel like we are okay to bypass this. Lower airway distress. So now we have asthma. Asthma we've talked about plenty enough times. It's going to be chronic inflammatory disorder of the lower respiratory tract. It tends to run in families, so definitely big history on it. We're going to have excessive mucus production, airway obstruction, bronchospasm. Plenty enough triggers to this. So there's actually 2 phases within asthma. So their first phase, we're going to have a release of our chemical mediators such as histamine. So what these things will do is bronchoconstrict and go ahead and fill up these bronchioles with fluid. And this will be our classic asthma attack. We'll see with wheezing. So you can kind of see their natural airway, and they'll kind of constrict, and then they'll just dump a bunch of fluids on our airway. Phase 2 is characterized by inflammation of the bronchioles as cells of the immune system invade the respiratory tract. You'll have just more edema. Don't worry about the phases. Just understand it's with one asthma attack, 6 to 8 hours later, they will still have symptoms. With these patients, with anybody shortness of breath with wheezing, you're going to want to reverse that bronchospasm with some albuterol. Assessments, we should already know all this, so we're good. Establish the airway, O2, beta agonist, albuterol, albuterol. Status edematicus is just going to be a prolonged asthma attack, recurrent. That's not going to be well responded with bronchodilator treatment. You are going to see some airway trapping with these patients. They're going to be very exhausted, very acidotic. Be very cautious and ready to intubate these patients. Very poor outcomes. Bronchiolitis, this is going to be very common in the pediatrics, very young ages, under about 2 years of age. RSV, which we're transporting everyone from, so it's going to affect the lining of the bronchioles. You have expiratory wheezing, and it's going to just look like asthma, but it's going to be a very young population asthma, common in the winter months. Assessment, you're going to have a family history of asthma, low-grade fever, and wheezing. Not too much to say about it. Same treatment as asthma. Pneumonia. So there's just going to be fluid within the lungs due to infection or illness. Very common in the ages of 1 to 5. Anybody who has a weak immune system or asplenic patients, just remember our spleen is a part of that lymphatic system and creates white blood cells. So without our spleen, we're not going to have the leukocytes to help fight off infections. So infection is very common, at least anywhere with no white blood cells, no protection. Signs and symptoms here are going to be our rhonchi, maybe some pain in the chest, increased respiratory rate, crackles, snap, crackle, pop, decreased breath sounds, low-grade fever. Management on these patients is going to be ABCs, O2, get a supply them, ventilate them if you need to. Since we do not carry it, unfortunately, CPAP would be a wonderful idea. Nitro and CPAP, or ipratropium bromide to dry up those secretions. But BVM, ET2. As we come here, we have more foreign body, lower airway obstruction. We have our shock, hyperperfusion. Let's see here. Okay, so our shock, you're not going to be perfusing adequately. Plenty enough causes. We pretty much all see these in our adult population. They just correspond right over to the pediatric. Keep them supine. They're going to have a really low blood pressure, so you kind of want to spread out that bathtub. Signs and symptoms. I'm pretty sure we know how to do all this. High flow O2, IV access, hypovolemic. We're going to give them fluids at 20 ml per kilo bolus, 5 to 10 minutes. Decompensated shock. So this is when you're kind of compensating. You're coming up that hill, and now you're going to start declining. The body cannot withstand the poor metabolic demand anymore. So the biggest hallmark is our decrease in decrease in our blood pressure. So in our compensated form, we have increased BP, and we have our increase in heart rate, and now it's just going to start declining. They're going to become more lethargic. You could see tachycardia or bradycardia. You're going to lose your peripheral pulses, weak central pulses, cool, pale, diaphoretic, hypotension, oliguria or decreased urinary output, absence of tears as they start secreting ADH. They're going to just start drawing everything back into their body, going back to the core. Irreversible shock is going to be, it's been going on for so long that you can't reverse it. GG's, thanks for playing. Types of shock here, we have cardiogenic, hypovolemic, obstructive, and distributive. Cardiogenic shock, keep in mind, it's going to be a pump problem, essentially. So when we do our fluid boluses, 10 mil per kilo on a cardiogenic, just because you have a fucking shit-ass pump, it's just not going to be adequate on giving a proper load of fluids here. Hypovolemic, easy enough. Obstructive, we have causes of P, cardiac tamponade, tension, pneumo. And our distributive sepsis is a huge one, anaphylaxis, and our neurogenic shock. Here we go. Impaired pumping of the heart, non-cardiogenic shock, anything other than cardiogenic. Simple enough. So we have our hypovolemic, and that's going to be a loss from intravascular fluids. So you can definitely see some big stages of nausea, vomiting, blood loss, of course, trauma, burns. When we do have a burn, you're going to have a release of fluids that go and start the clotting cascade and start the healing process. So a lot of intravascular goes up to that external portion of the body and kind of coats it and gets it ready for the treatment process. O2, IV fluids, 20 ml per kilo. Distributive, sepsis, anaphylaxis, cardiac output, and fluid volume are adequate enough. I don't think we really need to go over too much of what these shocks are. Septic shock, what do you know? Just assess them that they have sepsis and just treat it because they have sepsis. Gotta consider epi or dopamine drip. You have your formulas right here if you need it. Dopamine, take it, dump that 1600 Sorry, I'm brain farting right now. Yeah, 400 and 250 gets 1600. Anaphylactic shock. So you're going to be seeing the um, uh, immunoglobulins E. These are going to attach with basophils and mast cells and to release histamine and heparin. So yeah, well, we already know all this stuff. There's the degranulation, which is going to cause the allergic reaction. You're going to have a vasodilation and leakage of fluid into the interstitial space. So it's more of a pump problem than respiratory problem, really, in my eyes. You'll see things of tachycardia, tachypnea, wheezing, um, urticardia, and hypotension. Epi, above 35 kilo, you can get at the adult dose here. Under 35 kilo, 0.15. You can do that in the vastus lateralis of the leg here, or you can do the if this is your I'm not really too good at drawing. You can do your medial or just kind of anywhere in the deltoid. Neurogenic shock, yeah, should be good on that. Cardiogenic shock, just kind of be careful on fluids, 10 ml per kilo. Congenital heart diseases. So some common signs and symptoms that you may see with anybody with a congenital heart disease is definitely cyanosis. They may develop respiratory distress, CHF, and cyanotic spell. Treatment on this is not going to be too much. Give them O2 because they are cyanotic, and just treat them like you would. Put them on the cardiac monitor. IVs, KVO. My favorite. Cardiogenic myopathy. This is going to be actually a disease of the cardiac muscle itself. So you can see we have a pretty good left and right ventricle here. There is two forms. You have a dilated and a hypertrophic cardiomyopathy. So dilated, just big volumen. What do you know? You're going to have pretty poor or weak muscle fibers that aren't going to be able to push against this peripheral vascular resistance. Excuse me. So you can probably see an increase in heart rate, so you can keep that cardiac output up. And right here, kind of the same thing. It's going to be able to perfuse against that peripheral vascular resistance, but the only problem is going to be it's not going to be enough to support the metabolic demand of the body. So you'll probably see, yet again, tachycardia. These are pretty cool. With dilated, you'll see a lower QRS voltage, and with these ones, you will see an increase in voltage depending on the ventricle. So, pretty cool finding if you have a 12 lead you come across and it's got some weird voltage, something to consider. At least hypertrophic, you can definitely tell hypertrophic any day. What we got here? Cardiomyopathy. Yep, here we go. JVD, actually. Surprisingly enough, engorgement of the liver, just due to that portal hypertension. It's on the flow of blood back to the heart. O2 fluid should be restricted, just because this might cause some CHF if you overload on fluid. IV access and Lasix. Arrhythmias. We already know how to treat all this shit. We already know what it looks like. And then we already did go over some of the dosages. Just be careful. Don't shock them too much. You might get a burnt chicken nugget rolling through St. John Ross. So with our SVT, we're going to do 1 to 2 joules per kilo on our synchronized cardio version. If not, you remember, go Valsalva, do your vagal maneuvers, then consider, if we need amnio in the mix or adenosine, and then go ahead and go shocky. But if we got these hypertension, autonosis, and poor skin science, shock the fuck out of them. VTAC with a pulse, same thing. O2, IV, consider all this stuff. Synchronized cardio version. I would say, I actually did look into this. I am not sure if this is actually Macomb's actual official protocol, so I'll just leave it out there for now. But 1 mil per kilo. I would rather do a lidocaine. just easier to dose, and I mean, yeah, easier math, essentially. And then do your synchronized cardioversion, well, 1 to 2 joules per kilo. Bradyarrhythmias, consider epi, amio. It'd be very good. 0.02. I would consider doing atropine. Pretty easy conversion, just double it. 0.01. Pulseless arrest, PALS, your CPR, epi 3 to 5 Q. VFib pulses VTAC, CPR 2 joules per kilo, epi 4 joules per kilo. Consider this, that. This is all stuff we learned in PALS. Should be good. Seizures, these can be very subtle in nature. We already know how to take care of a seizure, I hope. Just be very careful. Anybody in a seizure, they're not going to be breathing, so bag them if you can, please. With our seizure patients that just finally come out of it, just get a BGL. They're going to be burning off all that ATP and sugar. They're one shot to begin with, and with all that rhythmic jerking motion, they're burning off that glucose, reduce ATP. So diazepam or lorazepam. You're mostly going to see that lorazepam in a hospital setting. And then if it's a febrile seizure, 15 milligrams per kilo on the acetaminophen. Yeah, quite a couple more here. So I'm going to stop it here for now. We're going to get into the cool one here. We do have our Koenigs and Brzezinski's signed. So we're going to go into a little bit more of these infectious diseases or processes.